in some ways, in thinking about this talk, I feel like psychiatry has let you down. Every time I talk about psychiatry, I end up talking about diagnoses and how to treat things. And what I really understand may be better than most, and what psychiatry talks about more than most, is what we're thinking about when we're with the patient. We ask ourselves, what are you thinking when you're with the patient? And it becomes a real part of the teaching process in learning how to be in the room with the patient. I come to this, I used to be an obstetrician, and you've been here before. How many have been here before? Oh my Lord, you've heard all the, I don't have but 25 stories, maybe 30. and they just recycle and recycle. But I was an obstetrician. I delivered a couple thousand babies. I went into a crowded surgical dressing room in Wilmington, North Carolina. I had decided to be a psychiatrist. Horace Moore, you heard the story? General surgeon, the least psychologically minded human being I've ever known, and the best surgeon. Horace had been waiting for me to come in the dressing room because he knew I decided to be a psychiatrist. We're in Wilmington, and I walked in, and with a crowd in there, he said, "Well, I understand you're going to be a damn psychiatrist." That was about 18 syllables. I said, "I am, Horace." He said, "I just soon pump gas." I said, "Horace, you know, if I ever really got anxious, I'd go to the Exxon station before I came to see you." And he said, last words were touche. But I did. And I went back to psychiatry school. And I want to talk about what I learned, and I want to read you a paragraph that when I first heard it, I thought, what the hell? This is a seminal article by Groves on taking care of the hateful patient. It was in the New England Journal. He was at the MGH. James Groves says, "Hateful patients are not those with whom the physician has an occasional personality clash. Rather, they're the patient whose names evoke cold dread every time they appear on a doctor's schedule or in his or her phone messages." Or in my case, I could drive in the parking lot and there were certain cars that I would just go, "Go!" I want to go home. That would certainly describe the patient whose calls and visits never failed to induce in me a long and silent groan. Groves argued that if the physician owns up to his or her negative feelings and characterizes those feelings, treatment becomes more effective. If you can recognize what you're thinking and why you're thinking it as you're taking care of difficult patients, then it changes the way that you feel and it changes your care of these patients. There's a new kind of approach now called being the difficult patient. With people saying, you know, in this day and time, with all this change in the practice of medicine, I find that being a difficult patient helps me get through my doctor visits. I advocate for myself. I make sure when I'm in the hospital that somebody's there with me. I'm not about to be in the hospital by myself. I want somebody there with me. And they find that being a difficult patient helps move the care. So the perfect patient is all, they comply, they're grateful, they're on time, and then we, the perfect agent, are all-knowing, all-caring, all-loving. That's the perfect agent. I took care of a lot of groups of people when I was an obstetrician, and I found primary care school teachers the best. On time, don't use substance, don't mind waiting, understand that you've got other people you're taking care of, and generally showered and taken care of. So not everybody, there's not a reason for everybody. This is my chairman's favorite slide. He says I can only borrow it This is Jimmy. Jimmy's not going to change. Jimmy comes from a long line. And Jimmy's going to be the way he is forever. And the point is, you're surely not going to change him in your practice. You can only make it so he's tolerable to you, and you take the best care of Jimmy you can. I have one other cartoon, and I want to give it to you because it's adolescent psychiatry, and this is the whole of adolescent psychiatry, the next cartoon. This is what I'm an adolescent psychiatrist. This is what I base my practice on. That's all teenagers want. They're not going to ask for it. They're never, in the history of the universe, has a teenager said, I'm going to a party. There will be sex. There will be drugs. There will be chaos. Please stop me. Don't let me go to this party. Doesn't happen. It's their job. Supervise, supervise. Okay, this is what we're expected to do, and this is what people with personality disorders don't do so well. They're not independent, they don't follow rules, and they don't have long-term relationships. If you went to take your boards in psychiatry and you were to ask one question to somebody to kind of get under whether or not they had a borderline, which we're going to get to, personality construct, it would be, do you have long-term intimate relationships with both men and women without sex, drugs, or alcohol? And if somebody says yes, they ain't got a borderline personality disorder, because people can't tolerate long-term intimacy without sex, drugs, or alcohol in each other. Doesn't happen. It's the one question that defines rule out. The last is no traitor style. We all have, and don't confuse eccentricity, but we all have moments where we look like we have a personality disorder. At any given moment, a teenager, if you just stop the clock, looks like they have a horrible personality disorder if you just stop and look at what you see in that second. But it's enduring. And it affects all of these things, and these are the ones we see. Maybe the most obvious one is interpersonal functioning. That's the one we see. And when Groves wrote this great article, he broke it down into demanding rejectors, deniers. He had people broken down into different sets of difficult patients. So, if you in psychiatry with this DSM-4 and 5 and all the things we've got, nobody has a disorder if they don't have dysfunction. If you don't have dysfunction or you don't have misery, you don't have a disorder. We all carry around this stuff, but the implication is that you have misery or dysfunction. So we talk about these personality disorders because we don't have another way to talk about things that are enduring. It follows you where you go. It doesn't cycle like depression. It doesn't cycle like anxiety disorders. It goes where you go. Generally, in a borderline personality setup, chaos goes where you go. It moves from marriage to marriage. It moves from town to town. It moves from job to job. And it just is with you because it is you. It's a part of your functioning. And when it comes to your office, it begs for some very poor care. So if you're trying to treat in the last one people with depression or people with anxiety disorders and they have a personality disorder, you're up against a wall. And in the end, all I'm saying is, if you find yourself trying to treat a personality disorder, you're making a mistake. You just try to maintain them, and you try to deliver the best care possible. And from time to time, remind yourself and them that you can't deliver perfect care. But you're not going to fix them. And in the end, you'll see that you need to pull your staff together because they will use all the primitive mechanisms they've got to get where they want and think they need to be. Splitting, good nurse, bad nurse, good doctor, bad doctor, passive aggressive, yes, cooperate, but covert sabotage, all those things that they bring forward. And we're going to talk about, both in this talk and the next talk, the concept of hypochondria. Has anybody in the last 2 weeks seen anybody that they would say would be a hypochondriac? That's all? Oh my God, come on. It's what we do. And I hope we leave today with your understanding that it's no more than turbo OCD. It's just turbo-fueled obsessive compulsive. That's what hypochondria is, and we'll come back to it and back to it. They can bring you to your knees. You're in charge of keeping them safe. You're in charge of keeping them from having things done to them that are potentially dangerous. That's your job. It's a hard job. It's easier to write to get a test. I learned about tests when I was a resident in OB. The test that doesn't need to be done, somebody got a Kim 200,000 on somebody, got everything they could get. Liver functions came back a little weird on a very healthy young woman. Long story short, chase, liver biopsy, bleed into Gleason's capsule, DIC, death. And from that point, Lou Welt, who ran the medicine department in Chapel Hill, made everybody tell him why they got a lab. Why are you doing that? Don't just go out there getting labs. And that's our job with people that come into us as hypochondria. And DSM-5 has decided to take hypochondria out because it's pejorative. We do some strange stuff in psychiatry, by the way. We add things, put things back. This time we've added gender dysphoria. Until 1965, you couldn't be depressed if you were a child. But after that, you could be, and we grandfathered all the kids in that had been depressed all along. Why and how do people get a personality disorder? Well, I think the most effective way to get a personality disorder is to be mistreated as a child. If you want to develop a borderline personality disorder, you will abuse a child. That child will then develop a personality disorder. Sexually, physically, emotionally. You pick it. It's the best recipe you can get. If you want to produce a narcissistic person as a child, you tell this child over and over, Mommy and Daddy love you with all their heart as long as you're doing great. Now, if you're not doing great, Mommy and Daddy are going to have to renegotiate this contract. But do great, and we'll love you. So all it develops in childhood. That's why child psychiatrists, of which I am, and an adult psychiatrist, believe that there's no such thing as new. When people don't get new things when they're adults, they get child things they didn't get fixed. It's all child stuff that didn't get worked over. So this is the personality disorder, and what we're going to do is go through just cluster A is the odd, eccentric, Robert De Niro taxi cab. You're not going to see much of that. These are the ones that are going to take you down and bring your office down. The cluster B, dramatic, emotional, erratic, and that's narcissistic, borderline, antisocial kinds of personality disorders. They act out. They act upon you. That's the ones we're going to talk about. So this is what we said. The patient wants to change. No, they don't, because they're not aware of it. That's part of the disorder. They don't know they got it. They don't know this is happening. They don't understand why chaos is following them everywhere they go. So they have zero motivation to change or be different. Somebody say? That's what psychiatrists always say when there's a noise. Everybody hear that? It's behind me. Okay. Well, psychiatrists always ask each other that. By the way, my other job, and this is probably personality disorder, my other job is admissions dean for the medical school at the University of North Carolina. And out of that, I have a multitude of wonderful stories. Most recently, this guy had a pretty good interview with me. This story, yeah, it does have something to do with personality disorder. We'd had a pretty good interview, and he got to the door, and I said, anything else you think I need to know about you? And he said, oh, yes, sir, you need to know I have charisma. And I said, I'll be damned. I said, I think I said, I knew I missed something, or what I think my colleague said, I said, you need to take something for that. It's very serious. Great stories with people. My most favorite personal statement was, I was born to be a leader. No, damn it, you were born to be a baby. Get out of here. You weren't born to be a leader. People say just absurd things trying to get to med school. This is what you see. The ones I think, these last three are wonderful. They're very mature. I'll go out and I'll do good. I'll laugh at what's wrong with me. I'll do the opposite of what I'm thinking. I want to be with a prostitute, so I'll go work in the red zone in New Orleans. The others get in our way. Splitting, take your staff, good staff, bad staff. Projection, I don't think you like me very much. I don't like you very much. Passive aggressive, one of my favorites. Overt cooperation, covert sabotage. Did you tell me to take that once a day? Goodness gracious, I've been taking it 7 times a day. Goodness gracious. These are the things that you see. They're the defense mechanisms, and they're the way people with personality disorder survive. This is what keeps them going. It's not their fault. They just can't keep going without using these mechanisms. So here's the part that psychiatry does a pretty good job of. We do a pretty good job of thinking about what we're thinking when we're in the room with the patient. Why are they making me feel this way? What is it that they're pulling for that's making me feel this way? I think they get better care and you don't get so crazy taking care of people. I don't think anybody understands what people in the healthcare business do. I don't think anybody really understands the power of what we do, of being in the room with the patient. And when I tell people that want to go to med school, what we do is blue-collar work, they look at me like, it's blue-collar work. You get on your outfit and you go to work and you work hard, and then you come home and you worry about what you worked hard about, and then you do records. We've been epicked. Have you been epicked? I got so hostile, and Randy's an IT guy. By the time Epic came around and I knew it was coming, I've got a bit of a personality disorder from time to time. It's not enduring, but from time to time, it's a combination of passive-aggressive, narcissistic, kind of acting out. I was going to my Epic day. My wife said to me, listen, it's not important so much that you learn today as that you behave. I would love to think that you'll learn, but I would please behave. Well, by the time, and let's see, where's distortion in there? By the time I got to my Epic appointment, I went in, and the woman running the Epic that day instinctively didn't like me very much, and I instinctively didn't like her very much. So I said to her, or at least somebody with me told me, I said to her, is this where we get our Epic helmet fitted? Then I said to her, I hope they're waterproof, because she said, you're in the back row. Epic. I do it. So let's talk about the dependent personality disorder. Remember we talked about independence being one of the expectations. A lot of our patients don't have independence. They become dependent on us, and it brings forth disagreements, disengagement. Doctor, make the decisions for me. And this was one of the James Groves patients that he talked about, one of the groups of patients. And he said, the way you take this on is these folks have to become responsible for their own care. And if you say that to them and you say, I can't do the day-to-day management and the moment-to-moment management, we've got to be collaborative in this. The days of prescriptive medicine are long gone, where I say you do this and then you go home and do that. That's long gone. This is collaborative medicine. So we engage this patient and say to them, I'm uncomfortable with how much pressure you're putting on me to take care of every detail. I can't do that. Clarity, clarity. I have a lot of patience. I want to do my best with you, but I need you in this. I had a person in my OB practice that had a dependent personality disorder. She had a disorder, she did. And when she told me she was moving, and I said, where? I think I said, how far? I meant to say where, but I think I said how far. She said, Washington, and I said, state? And she said, yes, and I just couldn't stop smiling. I thought, D.C., God, that's too close. OB story. So I'm delivering this baby in a garage in Wilmington because she went into labor, and I was jogging by, and I saw her, and I went in, and I said, Ann Frobert, you want some help? Yes. Precipitous labor, second baby. Les, the husband, had gone out back to light the grill to cook a chicken. I got a glove, got down on the floor with her. We're working. We are working. I said, let's have this baby right here. Let's don't be flying around the corner. We're 9 centimeters. Let's have this baby here. Les back in, and he said, Robert, do you want me to cut the grill off? I said, I did. I said, I do, Les. I do. I want you to cut the grill off and stay with it. This is the obsessive compulsive. It's different than obsessive compulsive disorder. Clarity, clarity, clarity. Rules, regulations, orderly, neat details. Medical students don't understand the difference between obsessive compulsive personality and obsessive compulsive disorder. This feels good. There's nothing wrong with this. I wonder why you're not that way. I mean, I don't get it. I'm Felix. I don't understand why you don't want everything perfect. Obsessive compulsive disorder doesn't feel good. The surgeon that has obsessive compulsive personality does an instrument count 3 times, they're out, gone. Obsessive compulsive personality does that. Disorder counts 87 times and can't stop counting. It's different. It feels awful, but they can't stop it. Antisocial, frequently charming. Antisocial used to look like antisocial. Antisocial wears suits and looks great. Madoff, he was antisocial.
Any politician.
She said any politician. Did you say lawyer? No, you said politician. Madoff, by the way, in the end, this is great. And I have a desire to go meet him. I want to meet him. Because in the end, Madoff says, of course I'm a crook. You people are so stupid. That's what he says at the end of all of this. I mean, good God, I'm a crook. Anybody can figure that out. But you people are so dumb. Taking 12% every year, believing you are so dumb. He's incarcerated 30 miles from my home. I want to go see him. I want to sit with him. Here's the mother of all personality disorders. Does anybody use the term, talk about the term? Do you know the term? Is it part of your world? Yes? Okay. Here's how it came about. It came about because borderline. We said this is not neurosis. Most of us are neurotic. And it's not psychosis. It's not crazy. But it's somewhere in between. It's in the border. It's in the borderline. Borderline people, again, let's come back to the question, do you have long-term intimate relationships with men and women without sex, drugs, alcohol? The answer is yes, you ain't got this personality disorder. The recipe is child abuse. That's the way it happens, and we see people in the hospital that will say to my resident, you go find out how the abuse occurred because I'm telling you this child has been abused. Your job is to help me understand how it happened. Now, in the turning over of what's happened to somebody, we have an obligation. We can ask anything we want. We've got that priority. But I think we have an obligation to make sure we cover up and smooth over what we ask. It's like reperitonealizing an abdomen. If you don't do it, everything's going to stick together. You're going to come back and have a mess. I can ask you about that rape in great detail, but I have an obligation to be so careful about what I'm inducing in your thoughts and what I'm bringing back forth. I have such an obligation to reperitonealize anything I ask. I get to ask anything. Intense, unstable relationship, always less achievement than imagined, constant state of crisis, and here's the deal. If I've got a borderline personality disorder, I had rather be in a negative encounter with you than no encounter. It's hard to understand, but I am much, much more satisfied if you and I are in a negative encounter. So you got to keep me encountered. I've got to have drugs, sex, alcohol, chaos. I got to have something to keep me engaged because I can't just sit down and read a book and listen to music or think about my mother's voice. I have zero ability to self-soothe. None. So you got to provide it for me. Your office staff has got to provide it for me. My illness has got to provide it for me. Oh, and by the way, if I lose my illness, am I going to lose you? If I lose my symptoms, am I going to lose you? Might be something nice to say to a lot of personality disordered people. I'm with you. Let's get you well. You don't have to be sick for me to be with you. This is maintain, not fix. If you think you're dealing with that. And people will have a borderline personality disorder for a period of time. I saw a young woman that was 17. She had a placenta previa, thought she was going to die. And she had for about a month and a half in the hospital borderline personality. But when she had the baby and she wasn't scared anymore, came back, didn't have one. So here's what happens. The difficult, and I get a call once a year or twice for the last one, which is, if I'd have known, it's from a man, if I'd have known that she had a borderline personality disorder, I'd have never gotten involved with her. Back up one step. Maybe not gotten involved with her anyway would have been a smart thing to do, but it ends up with all sorts of stalking and things. That's where you think. I'm sitting in the room with a patient, I'm thinking, why am I attracted to this patient? What is this attraction different than, more than? Let's say, what is it that I just dislike so much about this patient? Oh, I know. And then comes these other terms, which I got to give to you. Oh, I know. They're very simple. Transference in the patient is I take old relationships and I bring them into the room with you. There's never, my favorite social worker says, two people talking to each other in this encounter. I've got my whole gymnasium full of people and experiences I've had in my life. I'm the patient. The doctor's got the same thing, countertransference. I've got all of these experiences I've had in life, and they're very active in the room right now. And it is people and situations just like you that make me feel angry, impotent, seductive, whatever. All you do is running your tape. What is it that's going on? I'm thinking, I'm out of order here. What am I doing? Why have I not checked that fetal monitor, or why have I checked it 65 times? What's going on here? Keep asking yourself how you got where you are. I had a formula once in a while. How many baby deliverers in here? How many people have delivered babies? Once a blue moon, you'll deliver a really, really, really ugly baby. Apgar 10 and 10. Parents are wonderful. Baby just ugly as can be. And you can't think of what to do because you know you can't say this is a beautiful baby because everybody in the room knows this is not a beautiful baby. So you say, this is a blessed baby. And so my nurse Tammy used to say, Dr. Bashard, we've got another, my other word was precious, we got another precious baby here. And that meant we got a really, really, really ugly baby. These kids come back to me in Chapel Hill because their mother sends them, and they say, I want you to go by and see Dr. Bashford because he delivered you. I just want you to go say hello to him. So they'll show up, toboggan on, middle of winter. He didn't want to come at all. He said, my mother said I should come see you because she said you delivered me. You remember me? And I said, you didn't have the damn toboggan on when I saw you last. No, hell no, I don't remember you. So, if you keep thinking about how you got where you got, recognize that oh, by the way, there's a hospital transference thing people bring to you. One good question to ask somebody is, have you or your family had treatment here in this hospital? And if they say, yeah, my Uncle Jim, they killed him. He had a stroke. And those doctors killed him. You've got a hospital transference going. Or my Aunt Susie came in here and they saved her life. You got a positive hospital transference going. What have you had? When I tell my residents, if you have one question in the beginning to ask people, it says, what do you know about what you got? Tell me about what you know. Another thing I do with my residents is we'll leave, and I'll say, do you think that patient was psychotic? And they'll present the patient to me, and I'll say, you think that patient might be psychotic? And they'll say, no. And I'll say, okay, there were 3 of us in the room. 1 of us in that room's crazy. It ain't me. Go back in there and check it out. Somebody in that room is crazy. And they'll come back and say, oh, I'll ask a few more questions. Third from the bottom, disengaged. It sounds like a benign kind of thing. It's very malignant to disengage from a patient. So here's sort of the end is strike. I don't know what happened to the slide, but I can read it to you. Strike when iron is cold. I believe that. There's none of that ever works, ever. Now you hear me. Strike when the iron is cold. Maintain symptoms. Maintain a constant visiting relationship. Understand you're not going to change the patient. Maintain communication with your staff so they don't get caught up in the same thing. The patient with 10 complaints, and by the way, anybody that has more than 3 complaints has depression, until proven otherwise. 3 non-related complaints, they got depression or anxiety. So somebody lists 10 things, and you say, wait a minute, this was me. Let's just narrow it down. Let's talk about one of them today. Okay, let's talk. That patient says, well, what about vertigo? And I say, can you pick another one? We'll talk about I don't do so good with that one. Aim at symptoms, careful with meds, clear expectations, one voice. People call and talk to the nurse and the person at the front and your assistant and you, and they get variations on theme of a story, and particularly if they've got some kind of personality mix-up, they'll begin to come up with their own story, which doesn't have anything to do with what you want them to hear. So you and your staff come up with what you're going to say to the patient about her most recent whatever. And then lastly, I do think we're here to protect our patients. I think we're here to keep them from having things done to them. We got lots of ways to hurt people, just a multitude of ways to hurt people. I think part of our job is to protect patients from iatrogenic stuff.